Welcome to our next module on surgery of the gastrointestinal tract. Today, we'll be talking about timing of surgery, location of surgery, and of course, specific procedures for each of those areas. So an important distinction is going to be whether something needs to go to surgery immediately, whether it can wait, or whether this is something where you might want to phone a friend and have a specialist or a referral hospital involved. We'll structure this by talking about different disease processes and then how to treat them. First up, peritonitis, inflammation of the abdominal cavity. Of course, it can be septic or sterile. Septic with bacteria is the most common type of peritonitis. Gastrointestinal causes of peritonitis are the most common. Perforation, translocation, or dehiscence of a surgical incision in the intestinal tract are the most common causes. Other reasons why there may be peritonitis include urogenital causes, abdominal wall trauma, hepatobiliary injury or rupture or abscess, splenic abscesses or torsions. Pancreatic abscesses are uncommon, but absolutely a cause of peritonitis. For the purposes of this lecture, we'll focus on the gastrointestinal causes of peritonitis. First things first, you have to diagnose your peritonitis, septic peritonitis being the most common form. How are you going to diagnose peritonitis? By physical exam, history, clinical findings, but most importantly, you'll have to evaluate the fluid if there is fluid in the abdomen. Also, things like hypoglycemia, neutropenia, and hypotension will be common findings with septic peritonitis. Once you do discover that there's fluid in the abdomen, you will want to perform abdominocentesis. You look at this fluid under a microscope and with an analyzer. Low glucose, high lactate, and the presence of bacteria, both intracellular and extracellular under a microscope, are the defining characteristics of fluid from a septic peritonitis. These are always surgical emergencies, regardless of the cause. Rather than going into each individual body part that can cause a peritonitis, we'll keep going with gastrointestinal emergencies, and in so doing, we'll talk about surgery on each one of these areas, which will all go into how you would treat a peritonitis. First things first, of course, when you go in with your abdominal explorer with peritonitis, you will evaluate each and every one of the abdominal organs and determine the cause. In this lecture, we'll talk about surgery on each of those organs that will correlate and pertain to any case that you have with peritonitis. So, next up in our conversation about GI surgery and particularly GI emergencies is GDV, or gastric dilatation and volvulus, one of the most common reasons why we'll be performing emergency surgery for a gastrointestinal cause. These are definitely always emergencies. Do not want to sit on a gastric dilatation volvulus or a GDV. How will these dogs present, and how do you diagnose a GDV? They tend to be quite characteristic. A dog will come in, a large breed dog usually, deep-chested, with a history of unproductive retching and rapid abdominal expansion. Sometimes their abdomen will feel tight like a drum. Tympanic is the word we would use, but owners will often say that their belly literally seems like it's a drum, that it is full like that. So the first thing you do when you come in is evaluate the dog, make sure that they're stable. Dogs with GDV can often be hypotensive, sometimes they'll even be recumbent and very, very unstable when they come in. If you're able to, get x-rays immediately. Right lateral is the view you'd like, and what that will show you is that the pylorus is in the wrong position, that the stomach has twisted. So the x-rays will show you your diagnosis. Once you've made your diagnosis, what do you do next to get the dog ready for surgery? Most importantly, fluids. When the stomach expands, it causes compression of the venous system, the vasculature going back to the heart, and that's why these dogs can present in circulatory collapse. Either trocherizing the stomach or passing an orogastric tube are both very, very reasonable. Studies have shown that both are equally effective in decompressing the stomach. Once you've done so, and you've gotten some fluids running into the dog, large bore catheters, ideally in both front legs, then you can start thinking about planning your surgery. So as important as the surgery is your conversation with the owners, the clients, so they know what to expect. There are potential complications with GDV or gastric dilatation volvulus surgery. Unfortunately, anesthetic death has to be one of them because these dogs can be, as I said, in circulatory collapse. Sometimes they'll also require a splenectomy. With the stomach comes the spleen when it rotates because of the attachment with the short gastric blood vessels. Sometimes those blood vessels can tear and compromise the vasculature to the spleen. So approximately 15% of dogs with GDV will require a splenectomy. Back to that conversation about septic peritonitis. The stomach can become necrotic if there's been a loss of blood supply, and there can be sepsis and peritonitis associated with GDV. In those dogs, or dogs where there's a portion of the stomach that looks very unhealthy, about 20% of the time in some older studies, you may need to perform a partial gastrectomy, removing an abnormal or unhealthy portion of the stomach. Cardiac arrhythmias are also very common with GDV, about 50% of the time. Another thing you can talk about is blood loss or hemoabdomen with tearing of those blood vessels. Not always as common, but something you certainly can see. Another conversation to have with the owners is that the Gastropexy procedure, which we'll discuss next, is very successful, but dogs can still have a recurrence of gastric dilation even with a gastropexy. So what are some things that we can use to help guide the owners and guide our conversation about prognosis and how well these dogs are going to do? There are certain things that we know from several research studies are prognostic. One is lactate. The higher the lactate on presentation and the smaller the decrease in lactate after IV fluids and resuscitation, the worse their prognosis is. I could tell you the exact numbers, but you're not going to remember them, and you don't have to. Those guides are very important. High lactate on presentation, lack of response to therapy are both negative prognostic indicators. Gastric necrosis. Dogs with gastric necrosis are 11 times more likely to die than those without. Lactate can also be correlated to gastric necrosis, so you can use those two in tandem. Other things to think about are if the owner chooses not to go to surgery with a GDV, the dog may be able to recover from this episode. The stomach may derotate on its own after you've performed your decompression, but the risk of recurrence is very high, greater than 80%. So again, these are determined to be surgical emergencies almost all the time. So the owner has agreed to go forward with surgery and you're about to get started. What does the surgery look like? First things first, get in there and derotate the stomach. You usually can't do anything else in terms of an abdominal explore before you've derotated the stomach and gotten all of that gas and fluid out of there. I always like to have shortcuts. It can be hard to remember in the heat of the moment when a patient is unstable exactly which way the stomach is twisted. Is it clockwise? Is it counterclockwise? You're not going to remember. I don't always remember. What I like to tell myself is most of the time the stomach does twist in a clockwise direction. If you're standing on the surgeon's side of the pet, what does that mean to derotate? I tell myself, push down with your left hand. If the stomach has rotated clockwise, to derotate it, you're going to push down with your left hand and up with your right to derotate the stomach. Now, remember, there can be multiple different degrees of rotation. 180, 360, sometimes 720. And in a very rare circumstance, it can actually rotate the other direction. So keep that in mind. But if you think push down with your left hand, your life is going to be made a lot easier. Once you've derotated the stomach, sometimes you'll still want to pass an orogastric tube, very frequently in fact, to get rid of the remaining fluid and gas that's left in the stomach. And then you can get started with your abdominal explore. Make sure you've evaluated the entirety of the stomach. The spleen, feel the blood vessels to the spleen. Feel for good pulses to the spleen. That's going to be a very good predictor of whether you need to perform a splenectomy or not. To evaluate the stomach and its health, color is very helpful. A little bit of bruising, redness, very common. Petechiation, that sort of hemorrhage pattern, very common. But if something looks dark purple or black, or of course if there's a perforation, then you'll want to remove that portion of the stomach. For a partial gastrectomy, very similar approach as if you were doing a gastrotomy in terms of closure. Open up the stomach after placing your stays and holding the stomach elevated, pack off with laparotomy sponges, resect the abnormal portion, close in 2 layers. Usually it won't interfere with where you need to do your gastropexy. Next up, your gastropexy. The gastropexy incision should be placed about 3 to 4 centimeters away from the pylorus, oral to the pylorus in the pyloric antrum. This incision is partial thickness. It goes through the serosa and the muscularis, but certainly not all the way through the mucosa into the stomach. Once you've made this incision, you then make a matching incision on the body wall, going through the layers of muscle so that your gastropexy incision is muscle to muscle. That creates a strong and secure gastropexy. You want your incision on the body wall to be caudal to the ribs. Really important. If it's too far cranial, you can incise the diaphragm and allow air to go into the thorax. Don't want that to happen. You also want to make sure that your body wall incision isn't too close to your midline incision. God forbid that dog needs to go back to surgery in the future. You don't want the next surgeon going into the stomach by accident. Feel the tension. You want to make sure that there's a little bit of tension in the stomach to keep it in the right position. You don't want to be pulling too hard. A special trick that my mentors taught me is once I make my incision in the stomach and the pylorus, there will be a bit of bleeding. You can bring that incision over to the body wall and kiss the body wall. And then that little piece of blood, that little spot of blood, will tell you the best place to make your body wall incision. I always thought it was really helpful to let the stomach kiss the body wall to tell you where to make your incision. Gastropexy, the type of gastropexy that we recommend is the incisional gastropexy. Simply suturing those 2 layers of the stomach to the body wall. There are multiple different types of gastropexy, circumcostal, belt loop, all of those other sorts. They are possible, but they're not necessary. The simple incisional gastropexy is best. Very, very high success rate. The incisional gastropexy has been shown to have a near 100% rate of success for preventing GDV in the future. So really successful procedure. One thing to keep in mind is that dogs can sometimes have a transient GI upset from having their stomach in the abnormal or new normal position. So I do warn owners that particularly for the first couple of weeks, they should be fed smaller meals more frequently, and sometimes a gastroprotectant or antacid can be helpful. Another incredibly common reason for taking dogs and cats to surgery for gastrointestinal emergencies are foreign bodies, foreign body obstructions. Linear foreign bodies as well as nonlinear foreign bodies, completely obstructive foreign bodies, as well as those that may be partially obstructive. These are incredibly common and the presentation can be quite variable. Sometimes it's a slam dunk. It's a dog, we know he ate a sock 2 days ago, is now intractably vomiting. Makes a lot of sense. We also have other cases where we're not sure. The story is a little bit less clear. So how are we going to tell if there is a foreign body obstruction? Certainly, blood work can be very helpful, electrolyte imbalances. I'll let a critical care specialist in another vet candy lecture tell you more about that. But from a surgical perspective, the way we can tell for sure, or at least as close to sure as we can be before we go to surgery, are diagnostic imaging tests. X-rays. X-rays are your bread and butter. Start with X-rays. Look for different patterns of gas, different sizes or populations of bowel, so one that's very narrow and normal and one that's very dilated, that would suggest there's an obstruction. Other patterns to look for could be bunching or kind of scrunching of the intestines that may suggest a linear foreign body. Also, look for gas, free gas in the abdomen. That's another good indicator that you may have a septic peritonitis and there's leakage of intestinal contents into the abdomen. So if your X-rays are definitive, that's great, but very often we like to have some more parameters. There are studies suggesting that certain sizes in comparison of dilation of the intestines to the body of L5, the 5th lumbar vertebrae, can be helpful for determining your risk ratio of a foreign body obstruction. If the dilated intestine is 2 times the mid-body of L5, that does increase our concern that there's a foreign body obstruction. But Do you really need to measure it? Usually if you're looking at an x-ray and the intestine is that dilated, measuring it may not be necessary. In those times where you're not sure, ideally the next step would be an abdominal ultrasound. Abdominal ultrasound is much more sensitive. You can determine intussusception, you can determine the type of foreign body obstruction, if there's plication, but still keep in mind, again, studies have shown that the correlation between abdominal ultrasound, even in the best hands, is still not 100%. I always warn owners, there's always the possibility we find something in surgery we didn't expect on an x-ray or an ultrasound. Another important distinction is the linear versus the non-linear foreign body. It's important for a conversation to have with the owners, but also in terms of timing. Linear foreign bodies are much more emergent in terms of we got to get this cat or this dog to surgery ASAP, versus a non-linear stable foreign body may be able to wait until the morning until you have full staff. How can you tell the difference? Again, clinical signs and history are important. If the cat has a string under its tongue, that's pretty clear, and that does happen fairly frequently. For one that's anchored at the pylorus, that's slightly more difficult, but x-rays and certainly abdominal ultrasound will be able to tell you that answer. If it's a non-linear foreign body and the patient is stable, or if you're not sure based on x-rays or ultrasound whether there is a foreign body, that's a patient who can probably get some fluids and be hospitalized. Usually, if we're not sure about the diagnosis, we avoid an antiemetic such as Cerenia, Zofran, ondansetron because we want to know if the pet is still nauseous and vomiting. For a linear foreign body, is conservative management ever okay? They've actually done a study on this. Gotta love research. In a population of cats with linear foreign bodies stuck under the tongue, they snipped the tongue in these cats, and 47% of these cats were able to pass the foreign body with release of the lingual anchor in 1 to 3 days. Unfortunately, if 47% passed it, that means that 53% either needed emergent surgery or they were euthanized. So I always take every single cat to surgery with a lingual anchor unless there is a significant reason why the client's unable to move forward with surgery. Dogs with linear foreign bodies have even worse prognosis or higher risks of peritonitis and perforation. About 30% of dogs, once you take them to surgery, will already have peritonitis or perforation, and 40% will require resection and anastomosis. Caveat here. That's a slightly older paper, and in my personal experience, those numbers are a little bit lower than that. So I don't tell owners those percentages. That's something for us to talk about, but I don't want to scare them and dissuade them from going over with surgery because I do think dogs can still do very well with surgery for a linear foreign body. So again, in summary, linear foreign body always needs to go to surgery as quickly as possible. Stable, non-linear foreign body likely needs surgery, but these are ones where you can take a little bit of time to make your staff is all in pace. So you've diagnosed a foreign body obstruction or foreign material present in the gastrointestinal tract. The first procedure we'll be talking about is gastrotomy, so incision into the stomach. I have some pretty cool pictures you'll see attached that are of a patient with a trichobezoar, so a long-haired cat who had just been doing a lot of grooming and managed to fill her entire stomach up with hair. So, to perform a gastrotomy, you of course first do a full abdominal explore. Ensure that the foreign material is only in the stomach, or of course, if the foreign material is in the stomach and elsewhere, you can certainly proceed to another portion of the procedure as well. Gastrotomy. Isolate the stomach with moistened laparotomy sponges and place stay sutures. I'll usually place those stay sutures a good distance apart so that I know that my incision won't interfere with the stay sutures. Place those stay sutures with hemostats and have either yourself or an assistant hold those stay sutures and wrap the laparotomy sponges around them so you make sure you don't have any leakage from your stomach. Once that's all in place, make an incision in a hypovascular area of the gastric fundus. Look for equidistance between the lesser and the greater curvatures to avoid bleeding and make your two-layer closure much easier. Make a stab incision into the stomach. It can be hard to make it all the way through the mucosa. It can go away from you, so make sure your stab incision is all the way through the stomach wall. And enlarge the incision with Metzenbaum scissors. So long handle, short blade, Metzenbaums, short handles, long blade, thicker, heftier, Mayo scissors. Metzenbaums are most likely what you'll want to be using in this type of a procedure. Once you've removed all the foreign material for the stomach, make sure you have suction available, because if there is an obstruction, there can be a lot of fluid in the stomach. Close the stomach in 2 layers. Your first layer will be an appositional, simple continuous layer with a monofilament absorbable material. And the second layer, after flushing, always flush between layers. You can trap an abscess in between layers of a gastrotomy closure. The second layer should be an inverting type of pattern. That can be a Lambert or a Connell or a Cushing. My personal preference is the Cushing. It is partial thickness. It does not penetrate all the way into the lumen. Connell is the same pattern, has an L in it, so it means you're in the lumen. A Lambert is also very appropriate, but it takes more tissue, much harder to do a Lambert in a cat or a small dog. Once you've placed your appositional, simple continuous, flushed, then do an inverting pattern, a Cushing pattern, then flush everything again. Make sure that you've removed everything. I usually do a second quick explore, make sure I haven't missed anything or nothing has kind of traveled from the stomach into the intestine during my gastrotomy, and then you can flush, change your gloves, and close the abdomen. The next type of gastrointestinal procedure we'll be discussing is the enterotomy, or incision into the intestine, usually the small intestine, to remove foreign material. It's also a similar procedure if you're performing GI biopsies. So take some of these tips and tricks in mind for if you're performing GI biopsies as well. Isolate the portion of the small intestine where the foreign body is lodged. Occasionally, you will be able to gently milk the foreign material back up into the stomach to perform a gastrotomy, or into the colon, and then you don't have to open up the intestine at all because the patient will just poop that right out. But if you do need to perform an enterotomy, if possible, you want to make your incision in a portion of the bowel that is most normal. So not the area where the obstruction has created a lot of redness, a lot of bruising. If you can push the foreign material just a little bit more aboral, that's great, into a safer and healthier area, but a lot of the time you cannot. It's not something that can be moved, it's lodged very firmly, and if you were to try to move the foreign material, you might damage the intestine further. In that case, I just pick the portion of the intestine that looks the best. Usually, it's right over the foreign material in the aboral, or away from the mouth, further downstream portion of the intestine. Isolate the portion of bowel. You can either use an assistant's fingers or non-crushing atraumatic forceps such as Doyen's. In a pinch, I have used sterilized bobby pins. Not recommended, but certainly better than nothing. Occlude either side after milking all of the ingesta away from where your incision is going to be. And then get ready to make the enterotomy incision. Using a 15 blade, I prefer to actually have my blade facing upwards, so not cutting down into the intestine, but rather having the blade facing upwards so that I will not be tempted to cut too deep into the intestine and go through the mesenteric border. Make a small stab incision into the anti-mesenteric border, and then be prepared to use Metzenbaum scissors to enlarge that incision as much as you need to. You could always make an incision bigger, you can't make it smaller. And remember how time-consuming closing enterotomy incisions can be, so try and keep it as small as possible without causing tearing as you remove the foreign material. Once the foreign material has been removed, you might want to consider suctioning the intestine. There can often be a lot of fluid backed up behind the obstruction, and you might make the pet feel better and make your job easier in closing without having fluid bubbling out if you suction the intestine. Carefully. Make sure your suction's not on too high. You don't want to give any bruises to the interior of the intestine. Once that's all done, give everything a little flush and get ready to close your enterotomy. Enterotomies are usually closed in a simple and interrupted appositional pattern. You don't want the mucosa coming out, and you don't want to invert to make the lumen of the intestine any smaller. Small cats and dogs, very small lumen. Don't want to make it any narrower than you need to. Some surgeons will close these incisions in continuous pattern. I prefer to just be better safe than sorry. I close these in simple interrupted because if one of your sutures doesn't hold, you'll have a much better chance of not having leakage if it's performed in simple interrupted. Again, appositional is important. If the mucosa starts coming out, there are some tips. As you're tying your knot and tightening it, what I will do is I will tighten and roll my knot away from the edge of the incision. And as you tighten it and roll it, you'll see that that mucosa will want to tuck back in. Really fun trick. If you have enough hands, another method would be to take a sterile Q-tip, a cotton-tipped applicator, and as you're tying your knot, have your assistant push down on the mucosa as you're tightening. Very effective as well. Once you've closed your enterotomy, you can leak test. Not every surgeon leak tests, but a lot of us do. Keep your occlusion on the intestine and take a very, very small needle, 25 gauge with a 12 cc syringe, and inject in a healthy area of the intestine away from your incision. Inject saline into the intestine just until you have the tautness of a water balloon and push on it a little bit to make sure that no fluid is coming out of your incision. Don't want to push too hard, don't want to tear any of your intestine or your sutures. Then, once you're happy with that, have your assistant or yourself loosen your instruments before pulling the needle out with your leak test. As you can imagine, if you have a system under pressure and you pull that needle out rapidly, it could tear. It could propagate that little hole from your needle, and you don't want to do that. So important to release that fluid before pulling the needle out. Next, flush, flush, flush. We know that no matter how clean we are, we've allowed some intestinal contents out. Flush extensively, change your gloves. Sometimes if I'm concerned about the intestine, I'll perform an Omental tack as well. Take the Omentum, wrap it around, and even suture it in 4 corners on either side of the incision. Most of the time, if the intestine looks pretty healthy, I'll just wrap the Omentum. Omentum loves to stick to suture. It will probably do its job without you helping it, but sometimes I'll stitch it in place just in case. So now, 2 of the scariest words in the GI surgery lecture, resection and anastomosis. If there has been a portion of the small intestine that's been damaged severely by the obstruction or penetrating foreign material, I've done this for a gunshot wound in a cat, you do have to remove the portion of the intestine that is affected. It can be scary, but take things step by step and be prepared, have a plan. The 2 most common methods of performing an RNA are with suture, so similar to an enterotomy, simple interrupted, some people do continuous, I recommend simple interrupted with a very small monofilament absorbable material with a very small needle. That is done in interrupted circumferentially around the RNA site. The other method is with a GIA stapler and a TA stapler. Much faster method, but can only be performed in larger patients where the staplers are able to fit into the intestine. So, either way, you know you have to remove a portion of intestine. Have your plan. Evaluate the intestine. Choose the blood vessels that you want to save. Certainly, you want to make your incision far enough away from the area of obstruction and damage that you're not leaving abnormal intestine in place. But even more important, you want to maintain blood flow and blood supply to the intestine that you're keeping. So pick your site by where the blood vessels are. Then you'll want to do atraumatic occlusion of the intestine that you're keeping on either side away from that blood vessel. Then for the intestine you're removing, traumatic occlusion with just regular straight hemostats. Then cut directly against those straight hemostats as sharply and quickly as possible. Also, blood vessels. You will have to occlude and ligate the blood vessels going to the portion of intestine that you're resecting, as well as those little mesenteric bleeders that you'll cut through when you make your incision. Many different ways to do this. Suture, totally acceptable. Clips, hemoclips, you can use those. If you have access to ligature, that's great too. Making sure though, of course, that you're not damaging any blood vessels that you want to keep. Also making sure that you've left enough mesentery behind so that you can suture closed your mesenteric rent. All right, you've made your incision, you've ligated your blood vessels, you've taken your diseased intestine off of the table. Make your RNA closure. The way I prefer to do a closure with suture is I'll start at the mesenteric border. On either side, you want to make sure that that area is done first. It's the hardest to see and the highest risk for leakage or dehiscence. Start at the mesenteric border and then go up either side your closure. There are certainly some surgeons who also like to place an anti-mesenteric suture in the center just to help guide them that there's 50% on each side and they don't end up with an asymmetry on one side of the intestine versus the other. Other tips and tricks, if you're going to use a stapler, definitely want to have stay sutures there as well. And make sure that you've played with a stapler before you get into an emergency procedure. Take a dry run. Even waste a single staple cartridge, it's worth it so that when you're in surgery, you're not worried about how to use the stapler. All of them are a little bit different, so very much worth working with them a few times before you have a patient that needs it. Once you've performed your RNA, you can also perform leak testing. Again, not everyone does, very similarly to the way you do with an enterotomy, and then flush like crazy. Change your gloves. My recommendation with almost every resection and anastomosis is to perform an Omental-pexy or Omental patch. Wrap the omentum around and place with that same small 4/0 usually suture, 4-corner suture to keep that omentum in place. Make sure that you're also being very careful that with those stitches, it's partial thickness, just taking a little bit of the serosa. Doesn't need to go all the way through. Closing the mesenteric rent, also very important. I have seen patients have entrapment and strangulation of intestine if the mesenteric rent has not been sutured closed. Doesn't need to be tight, but definitely need to repair that. So just like any other surgery, it's nice to know what some prognostic indicators are to better determine our own thought process about how to take care of the pet postoperatively, but also to have a conversation with the owners. So dehiscence is one of the biggest risks after any gastrointestinal surgery. Studies have shown that the risk after enterotomy of dehiscence or leakage is about 10 to 15%. For resection and anastomosis, it can approach somewhere up to 20%, anywhere between 10 and 20% depending on what study you read. Of course, excellent technique is going to help you in any one of these situations, but we can look at some risk factors. Depending on the study you read, the existence of preoperative or pre-existing peritonitis, so if this was a septic abdomen with a perforation in the intestine, that is a risk factor, unfortunately, for there being dehiscence and septic peritonitis even after the surgery. There's a lot of reasons for that, probably just general health of the gut, general health of the pet. Also, there are some enzymes in infections that can cause breakdown of tissues. So lots of reasons why a patient with peritonitis is at higher risk. Also, low albumin, hypoalbuminemia, can be a risk factor for dehiscence. Hypotension as well, with a mean pressure less than 60 millimeters of mercury, has been shown to be a risk factor for leakage following intestinal surgery. The good news is that the outcome for GI foreign bodies overall is very good, about a 91% recovery rate. And the degree of obstruction and the location do not influence survival. So I do tell owners that although there are real risks to GI procedures, the likelihood of recovery is very high and very much worth going through with these procedures. One thing we have to talk about, and we have to talk about with owners, is the concept of, again, we can call it this, don't tell them this to the owners, is the negative explore. What that means is our diagnostic tests, our hunch, our clinical acumen, pointed us in the direction of a foreign body obstruction, and there wasn't one when we got in there. I always prepare owners for this, except in circumstances where we know it's not going anywhere, like a cat with a lingual anchor. There's always the possibility that between the time of your diagnostics and the time you open up the belly, the foreign material could have moved. Sometimes fluids, opioids, anesthesia can cause smooth muscle relaxation and the foreign material can pass. I prep owners for this, and I always say it's for the best. I would much rather be safe than sorry in this circumstance. Sometimes it's also a good opportunity to do other things. If this is a pet that actually has chronic GI disease, it may be an opportunity to perform biopsies. If there's also a splenic mass, a liver mass, some other type of abnormality in the abdomen, you can treat it at that time as well. The words that I'll use with owners are functional versus mechanical obstruction, and I'll explain them. I'll say what we think is that there is a mechanical obstruction. We think there is a foreign body stuck there. That is most likely what's going on. There is a low risk that the foreign material may have already passed, or that the signs that we're seeing are actually because of a functional obstruction, or the intestine just not working normally, and then we have to treat medically. So again, negative explore is something we talk about. We can use that term ourselves, but owners tend to find that the negative connotations of a negative explore can be pretty upsetting. And I certainly understand that they're going through a lot with their pet and they want to feel like they're making the right decisions. A more uncommon type of presentation, but one that you may certainly see, is a torsion, so a twisting of the gut. That can be mesenteric torsion affecting the small intestine or a colonic torsion. These are usually young adult, male German Shepherds, pointers, and the presentation is usually pretty acute. These dogs are very, very sick because their gut has twisted and they've lost supply of blood to that portion of the intestine. On x-rays, you'll see a severe uniform distension of all of the bowel, except with a normally positioned stomach, unlike a GDV where the stomach is abnormally positioned for a mesenteric torsion. For a colonic torsion, you'll see that there will be a very dilated colon, but that can be a little bit trickier to determine exactly what's going on the intestines. Basically, very, very gas-dilated intestine where there shouldn't be will indicate potentially a torsion. Now, torsions, mesenteric torsions in general, are a very poor prognosis. If all of the gut has lost its blood supply, then there really isn't too much you can do. That said, in recent years, I've had a couple of atypical mesenteric torsions with just a portion of the small intestine, and with a resection and anastomosis, those dogs can do very well. A colonic torsion, if the colon is healthy, you can untwist the colon and perform a colopexy, and that can also be quite successful. So similar to a GDV, with a gastropexy, a colonic torsion can perform a colopexy. Sometimes a colonic RNA is required as well, and those are certainly more technically challenging, but I certainly wouldn't call it a final prognosis if I went in there and I diagnosed either one of these conditions if the intestine itself looked healthy. But certainly, definitely a very, very serious conversation to have with owners if you diagnose a torsion. Another problem, which is more rare than a GI foreign body, but less rare than a torsion, is intussusception. One of my favorite words in all of veterinary medicine. So many S's. The two parts of the intestine that can telescope within each other, the intussusceptum and the intussuscipiens, will look like a target lesion on an ultrasound. They're very characteristic and kind of pretty if you think about it. So what can happen is, with hypermotility of the gut, two portions of the intestine can literally telescope one within the other. Most common presentation are young dogs, sometimes cats, but very commonly young dogs, less than a year old, with a reason for hypermotility, hypermotile gut. Parasites, parvovirus, linear foreign bodies, or other severe type of HGE or hemorrhagic gastroenteritis, something that makes the intestine push very, very fast and can actually make those intestines go within each other. So once you've diagnosed intussusception, approach it at surgery. You can manually reduce the intussusception, so pull those portions apart rarely. If it's happened recently and it moves apart very easily and the intestine looks healthy, you can certainly reduce an intussusception. However, the majority of the time, by the time we get into surgery, the intestinal portions have become damaged and it's a resection and anastomosis that's required. I've seen both. One thing I certainly talk to owners about is that there is a risk of recurrence with an intussusception. Whatever other underlying cause that caused hypermotility could still be ongoing, so that could happen again. One thing you'll read about is a procedure called enteroplication. And what that means is you take the entirety of the small intestine and curl it up like an accordion and suture it all together. Usually not something that's recommended, and certainly not with the first incidence of intussusception, because it's a very technically challenging procedure and can carry a high risk of complications in and of itself. So with an intussusception, definitely warn the owners of a recurrence, but if you treat the underlying disease process, you may be able to get these puppies through it. Some tips and tricks. Things you may want to consider to take care of your pets perioperatively, both before, during, and postoperatively. Nasogastric tubes. Nasogastric tubes can be a good friend in these situations where there are GI obstructions or GI issues that may cause prolonged ileus, prolonged vomiting, fluid buildup in the stomach. Nasogastric tube placed preoperatively is used to decompress the stomach. Certainly, cats with high obstructions and a lot of fluid in their stomachs can be prone to regurgitation and, unfortunately, aspiration at the time of induction of anesthesia. If I see on an ultrasound or an x-ray that I think there's a lot of fluid in the stomach, I'll do my best to empty the stomach prior to anesthesia. Usually the best way, NG tube. Not always possible. In a fractious cat, sometimes you just have to place them under anesthesia. Do that as quickly as possible. Have a stylet ready. Have a very experienced anesthesia nurse or tech available to help with the intubation, because speed is of the essence. Nasogastric tubes postoperatively can also be very helpful. If there's prolonged ileus and fluid buildup in the stomach, this can make the pets feel really crummy while that's resolving. So the nasogastric tubes can help relieve that pressure by taking the fluid out. Also, you can start trickle feeding, particularly if it's a dog or a cat that's finicky and unlikely to eat in the hospital, or a cat where you're concerned about hepatic lipidosis with prolonged inappetence. The NG tube can be a great way to start feeding them while in hospital. Other things to keep in mind: prokinetics. Reglan or metoclopramide, very commonly used in our patients with slowdown of the gut, nausea, ileus. Don't want to start a prokinetic until your obstruction has passed. You don't want to tell the intestine to push harder against ingesta when there's an obstruction. But very commonly, I will use a prokinetic postoperatively once the obstruction is relieved. This concludes our module on GI surgery. Today, we talked about septic peritonitis, gastrotomy, enterotomy, RNAs, torsions, intussusceptions, and GDVs.